I know yesterday we had a wonderful session with not one of the pioneers, but with the pioneer in GLP-1 research in the world, taking the GLP-1 from the gut to the clinical situation as treatment of type 2 diabetic patients, Jens Holst from our university. I mean, it's really amazing to listen to him talk about a lifelong achievement, taking this, as I said, from the gut to use in clinical practice. What I'm going to discuss with you today is what have happened so many years later after it became a clinical drug for use in type 2 diabetic patients, where now it not only has effects on lowering blood glucose, but also has important effects on these important comorbidities of type 2 diabetes. And being a nephrologist and being in this session, what I'm going to talk about is the outcome, the effects on these agonists on renal disease in type 2 diabetes. Now, we just heard from Rima about RAS blockade. And I mean, this is just what we do. I mean, we block the system. We have done that for many, many, many years. And it really changed the world, beginning to do that. And we have done that for so many years that many of you have never been doctors without having this treatment. But it really was very, very important when it started, because it changed the clinical picture quite a lot. And we just heard about all the wonderful effects of this, and I'll just show one slide on RAS blockade, which is very important. It's from one major study called the STENO2 study from Denmark of multifactorial intervention, slowing the progression of diabetic renal disease and type 2 diabetes and having effect on cardiovascular disease. And I show it because it really showed some clinical important effect of endpoint, even many, many years after the study had stopped, and where you still, when you examine the groups that had originally been treated, so how it had effects of incidence of death from any cause, incident of cardiovascular events. So it's just to say that this changed the world, and of course this is the basis of our treatment today, and all studies of today on GLP-1, on SGLT2 and all that has as a basis this treatment. This is standard of care. And I'll show you that in Denmark, for instance, it had another very clinical significant effect. If you look back in time, 30 years ago, and many, many years to come, the number of patients with diabetes progressing to end-stage renal disease increased by almost 10% per year. And it was so all over the world. And all us nephrologists, we had a battle increasing the volumes, being able to treat all these patients, and there was a growth and all the time. And then about the time when this treatment with RAS blockade really had been implemented, then as you can see, it flattened. So it had not only on cardiovascular disease and mortality, which of course is, I mean, if you live, it's good. But if you live without end-stage renal disease, it's even better. And just to show that there was an important effect on this. So this is good. But as you can also tell, there still are so many of our patients, we all know that still have problems. So there still is a major problem. And therefore, we of course have been looking for many, many years on new pathophysiological mechanisms, and not to mention new treatments. And I mean, this is almost old news now, that new treatment principles, we are discussing those so much these days because they have shown efficient, and that's after 20 years without any significant improvements in treatment, I would say. Then suddenly we had these two new treatment principles. And we are discussing two of those today, and my friend Frederick will, after me, discuss the SGLT2 inhibitors, which of course is a major breakthrough that we'll all are very pleased to listen to, and I'm going to talk about the GLP-1 receptor agonists. I would say these days, everything is about SGLT2. everything is about SGLT2. I'll just remind you that there is also a clinical position for the GLP-1 because they can also do something, and maybe the combination is important, and therefore I think this lecture is in its right place, just to remind you that SGLT2 is a breakthrough, but there is also a story about GLP-1 agonist, and that's the story I'm going to tell you about. Yes. We heard yesterday everything about incretin hormones, type 2 diabetes, so I'll not tell about the mechanisms, how it works, and how. I'm just going to tell you another story. But I will tell you, if you have forgotten, there are two different ways of having the therapeutic potential of GLP-1 realized. And that's because you may know, and from yesterday, that the glucagon-like peptide 1 it breaks down almost immediately when it's released from the gut. Within minutes, it's gone. So, therefore, if you take some GLP-1 and you inject it, then it's gone within minutes. So the two treatment principles that we have today, they have to do something about that problem. One of those is the GLP-1 agonists, with some resistant analogs that are not broken down, and these are the ones where we have the evidence of an effect on complications, I would say. That's what I'm talking about today. And the other mechanism that is easier because they can be taken as tablets are those who inhibit the enzyme that breaks down the GLP-1, right? Yeah, so I mean, and we like to use those because that's a tablet. But we have no evidence on the late complications with those, but they improve the blood glucose. Whereas the GLP-1 agonists, we have to inject them, and we have some evidence on complications with those, and that's what I'm going to talk about today. But I'm sure you use the tablets for the most. I just told you about that. Okay, just to start, I'll show you that with these agonists, there are a number of studies, and some of those show consistent kidney benefits compared to placebo. But I will also tell you through my lecture that the endpoints in these studies are not as hard as with the SGLT2 inhibitors that Frederick is going to. So you're going to be the hero today, Frederick. And I'm going to talk about something that may be promising in the future, because the endpoints in these studies are not as hard as those on the SGLT2 inhibitors. But in a number of studies, there is a shown favor in this forest plot. I'll have to find it on the GLP-1 agonist, and those are what is called the LEADER study, the SUSTAIN study, the AWARD, and the REWIND study, and these are the studies I'm going to take you through now. Okay. So to start with the REWIND study, they were studying the drug called dulaglutide, which is a drug given subcutaneously once weekly, and they studied the cardiovascular outcomes in type 2 diabetes. So, of course, the cardiovascular outcomes is a major outcome in every study, also in the SGLT2, but we nephrologists, of course, are very pleased when it also helps. As I said before, I'm very pleased if people live longer. Okay, good reason to give a drug. I'm also pleased if we can make them live without kidney disease. So, but anyway, this also started on the cardiovascular outcome, and they included a high number of patients, 9,901. And I mean, the STENO2 study, as I showed you before, had about 80 in each group or something like that. So I mean, it's been more difficult today to show effect on the hard endpoints, but that's very, very beautiful when we are doing it the right way. And what they did in this study, they studied all these patients randomized to, I have to find the arrow, to dulaglutide or placebo, once weekly subcutaneous injection compared with standard of care, and standard of care is what we just heard about. I mean, that's anti-hyperglycemic treatment and any RAS blockade and lifestyle intervention and so on. It was an event-driven study, 1,200 first primary cardiovascular outcomes, and as you can tell over here, it was type 2 diabetic patients. They had to have different ages depending on the other cardiovascular components that they had. And then, and that's important for the nephrologist, They included patients down to an estimated GFR of 15 milliliters per minute, and therefore there's also a story in this study about patients with reduced kidney function. And that's of course nice to know, because for one thing it tells afterwards we will know if they could have the drug without serious side effects when the kidney function was going down, and I'll tell you they could. And the other thing, we also have the opportunity to see if there was any specific effect on progression of kidney disease. So that's therefore it's important to know in this context about the kidney function in these studies. And the objective was whether they could reduce the incidence of cardiovascular and renal outcomes in this group of patients. Okay. And actually there was an effect on the composite cardiovascular outcome, as you can tell from this, placebo, dulaglutide, and there was a beneficial effect. I will then say that some might say that it was not that big, but it is there. That's important. So it doesn't do any harm, and there is some benefits. They are significant from a statistical point of view, and even on a minor scale, I would say, on a clinical point of view. And when it was broken down to the individual components on the cardiovascular outcome, you should down to get any of these components that was significant by itself. It was a non-fatal stroke. It's just to have an understanding. So apparently it's safe to give this drug to our patients with type 2 diabetes down to a GFR 15, saving those on the cardiovascular side. But there was also some outcomes on chronic kidney disease. And this is the composite renal outcome. And again, I would say, as you can tell, I'm not selling a drug. I'm saying there was an effect, maybe a bit disappointing from a clinical point of view, but it was there. Okay? That the composite renal outcome, they came out better in the treatment group than in the placebo group. High statistical significance, maybe a minor clinical significance. And one of the disappointing things, I would say, therefore we need more studies, was that the effect is mainly driven by changes in proteinuria. I'll show you that. So, I mean, this composite endpoint, what really takes this to a significant level is the changes in proteinuria and not on the harder endpoint. But still, there may be a promise there. There was perhaps a trend to a beneficial effect on the loss of kidney function in terms of estimated GFR, as you can tell from this. And there was, and as I told you, a significant effect on the proteinuria. Are we happy? Well, I'll say, I don't know. It doesn't harm. It may be beneficial. I would say more studies are needed. I would like to also give the lecture that Frederick is giving, because SGLT2 is a big one these days, but there may be an important story here as well. Okay. This is again macroalbuminuria, significant development difference there. Sustained effect on eGFR. Well, renal replacement therapy. And then they try to break it down on different levels on eGFR, and when you do all these secondary subgroup analysis, you can find a significance. Okay, yes. Summary of these, again, that's what I've said, and you can, as you can tell on the forest plot, everything is on the right side. Yeah. So, another study, similar, not Rewind Award, they included patients not based basically or mainly on their cardiovascular disease, but on their chronic kidney disease. I mean, in many ways there was an overlap in the groups of the two patients, but in this study, you entered the study based on presence of chronic kidney disease. Yes, and in this, again, once weekly dulaglutide subcutaneous in 2 different dosages compared with insulin. The primary endpoint after 26 weeks was analyzed, and after they've continued the study, and then the secondary endpoints, they came out after 52 weeks, just to understand the design of the study. And there was in this, to get the power for their endpoints, they needed this number of patients, and they wanted to assess the efficacy and safety of dulaglutide in patients with type 2 diabetes and moderate to severe chronic kidney disease. So, of course, it's more, being a safety study, it's more, they didn't need that many patients, but actually they had an outcome which, again, I'll show you, supported the outcome of the other study. Yeah. They included patients with CKD stage 3 and 4. I'll try to find, it's a very small, here. Stage 3 and 4, and many of you, maybe all of you, will know that that's with an eGFR down to 15 and up to 60, isn't that right? So it's a span of patients where everybody wants to study these patients. Yeah, it's an important window to treat patients. Yeah. And in this study, they actually found a difference in the change in estimated GFR over time, showing that the insulin group lost kidney function a little bit faster than the treated group. So again, personally, I think eGFR, if that's the only one and a minor difference, it's still not a hard endpoint, but it is an interesting endpoint, I would say. Yeah, and these are again broken down to now they talk about the different the dosages, which was more effective than the other. Yes. So this was the story of 2 important studies of dulaglutide, and now there are 2 other studies. With liraglutide and semaglutide, and the major difference is, for one, it's a different company, and the other is that liraglutide is given once daily, and semaglutide is also given once weekly and subcutaneously. So, yeah. And the first of these was, they were both planned as non-inferiority studies, but the happy thing about them was they also came out with a superior endpoint. I'll show you that. This is shown on top on the cardiovascular. Is it easy to see there? Yeah, it's better than on my screen. This is the cardiovascular endpoint, again showing, as with the dulaglutide, in these type 2 diabetic patients that there was a positive effect on cardiovascular. And again, I say this is good. And then broken down to the individual components, there's a long discussion about that. But again, they analyzed the CKD, chronic kidney disease outcomes. And now these 2 studies, the leader and the sustain, are put together to take you through these 2 studies because they are so similar in many respects. So the leaders was liraglutide, giving subcutaneously once daily. The sustain was semaglutide, giving weekly, and compared with standard of care. 2 dosages going down here. And again, you just need 9,000 patients with type 2 diabetes. And again, since cardiovascular was the primary endpoint, it was a cardiovascular inclusion criterion. Okay. But they also took them down, included patients with reduced kidney function, down to, where do I find? I think it was also about, 25 milliliters per minute, but again, they had a CKD group in both studies included as well. And in this leader, the liraglutide, it was 9,000 patients. In the sustain, it was 3,000. So again, it was quite big studies. So when these studies, they also came out, as I showed you, with a cardiovascular endpoint positive. But again, with the combined kidney endpoint, they both showed beneficial effects of treatment compared with no GLP-1 agonist treatment. And again, the story is here that the combined endpoint was macroalbuminuria, doubling of serum creatinine, end-stage renal disease, or renal death. Renal death is always a very difficult one. I mean, what's that? Renal death is when you have a GFR below 15, have not yet been put on dialysis, and die. That's the same in the SGLT2. And in these studies with 9,000, there's usually 3 or 4 patients in that. It's just to tell you, just don't be too enthusiastic about that. It's just there. But anyway, with this combined endpoint, and in this one, they either didn't have any renal deaths, or, I mean, I don't think it changes anything. But again, you see a positive effect, okay, on both of these. 22% risk reduction, 36% risk reduction. But just to, again, share with you a little bit, I'm still saying the jury is out. We are still waiting for the hard endpoints. That in both studies, it was all carried through by new onset or persistent proteinuria. Whereas on the harder endpoint, the doubling of serum creatinine and need for renal replacement therapy, there was no difference shown. So promises in the leader, there was this change in this. Again, we need to be very careful. This was not the overall result of the study. This is a group of patients who had CKD stage 3. So that's higher than 30. So again, it has to be broken down. I would again say it is promising. But on the proteinuria in both studies, as with the dulaglutide in these rewind and award studies, there was definitely a clinical effect. And some would say that this is a hard surrogate endpoint. Yeah. Okay. Is there a renal mode of action? I mean, the blood pressure goes down in both studies. The HbA1c goes down in both studies. There's a weight loss. So there are a number of theoretical and practical clinical reasons why this might work. To summarize all of this, there are 2 studies going on, and particularly one with semaglutide, trying to investigate kidney outcomes in a study of renal disease patients with type 2 diabetic patients, which is specifically designed to find out whether it can do more than we have just seen. And I was telling you that there were promises, and there is a study that may give the answer whether this does anything. In particular, it's going on. Unfortunately, they are not randomizing any patients in Denmark, so we are not joining this study, but I know it's going, and it's going well in the world. With patients with chronic kidney disease, they have some pretty good endpoints, and they also have a study going more in detail on the pathophysiological mechanisms. So it may turn out that we get more answers and will be even more happy in the future. So far, I'll just say, because in a moment, Frederick is going to talk about the SGLT2, that there's no doubt that there is a place for GLP-1, maybe in combination. It can do a lot of the stuff that we would like to see when we are treating type 2 diabetic patients. But still, I would say on the hard endpoints, they still need to do some documentation. Yeah.
Thank you very much for this nice talk. Are there questions from the audience?
I saw one, Esteban. No, yeah, okay. No, that was another one. Yeah.
Thank you for a very nice talk. So now you just briefly touched upon what you think is the mechanisms behind GLP-1 receptor agonism and the effect on kidneys. So what do you think is the major mechanism? Do you think it could work together with an SGLT2 inhibitor?
Well, we know it can, but we don't know if it can mechanistically work together. I mean, we just work that you can give them together. We don't know about whether they have an additional effect being combined. And I really don't know about whether one mechanism is in favor and supports the other mechanism. I don't know. But I know that they can be together, which is also important, I think, in the future, because from tomorrow, maybe from today, not many trials can be made without patients having an SGLT2 inhibitor. So if they couldn't, they would never be tested. That's not an answer to a question. It's just to say you can give it. I don't know. I don't think any can answer about the other mechanistical, because if you look at the endpoints in these studies, which is mainly on proteinuria, I think that the effects, for instance, on the blood pressure, on the glycemic control, may in a way be all the explanation we need. I don't know.
Okay, thanks.
Do you have any suggestions? No.
Hi, Bo. Thank you for a nice presentation. I have two questions. The one you had to skip, but do you think the mechanistics of GLP-1 is direct or indirect? And the other question is to the DPP-4 inhibitors. Do you think that the effect you see with DPP-4 is due to GLP-1, or could it be GIP or on other DPP-4 targets?
Well, I'll start with a standard, very good question. I really don't know. I would say about the DPP-4, they still need to show what they can do on the hard endpoints studies. So I have not much to say about those. Yeah, on the GLP-1, I will more or less repeat my answer. There are so many theoretical. When you look at the animal models, I mean, there are effects on inflammation, and there are effects on many other theoretically mechanistic systems, but I really don't know, unfortunately.
Thank you very much, Bo. I have a question because your group has investigated GLP-1 in dialysis patients.
Yeah.
And we know that, or we think that the effect of SGLT2 inhibition is not very good when you have low GFR. Can you see a potential a gray zone of treatment where you continue a GLP-1 agonist into dialysis and fill up the treatment gap, where you have to probably stop SGLT2 inhibition because the effect is in the kidney is not functioning, and then continue with a GLP-1 agonist through dialysis, because we're not doing that today. We tend not to use GLP-1 agonists in the very low GFR patients.
Yeah. Well, I think time will show. As I see I don't think GLP-1, as you're right, we tested liraglutide in a group of hemodialysis patients. We could treat them, we could lower blood glucose, and in many ways you can do that. I would say they had the side effects, as you know, they really got nauseated. But in a way, on balance, they like to take the treatment. So, right, you can give it. We don't know what it does with hard endpoints at this time. And about the SGLT2, you're right, we don't know what happens when we go down below the GFR, say 15 to 20 milliliters per minute. As I read I'm sure Frederick will also approach this, I think many of us will start treatment with SGLT2 and probably will not discontinue as they go down. There is many theoretical possibilities that there are indirect effects. We don't know, but we may get a story to tell when we have enough patients going down with SGLT2 below. So will this be the place for the GLP-1s or not? I mean, I think the future will tell. Yes.
Thank you.